This was a referred patient by my colleague who had operated on him about 5 years ago, an uncomplicated SICS with an IOL. However, after 5 years, the IOL dislocated and the haptic was rubbing against the cornea. I couldn't dilate the pupil well, but I was sort of able to visualize the periphery of the bag. And I decided to take a decision on the surgical table as to what my plan would be. Now you can see from the picture that the haptic is rubbing against the cornea and the IOL is dislocated upwards. So since there was an incision superiorly, I decided to make a temporal incision, a valve incision. I put in some side port incisions as well. And my idea was first to dislocate this IOL with the help of iris hooks into the anterior chamber. And very easily I could dislocate this IOL into the anterior chamber. I was not very sure of the status of this IOL and hence I removed it, put in some more iris hooks to visualize the periphery, and I could see some calcified peripheral bag, and I thought probably there is a deficiency superiorly. So I put in another lens using that peripheral PC as a scaffold and making sure both the haptics were placed horizontally, completely away from the presumed superior deficiency of the bag. Then removed the iris hooks, removed the OVD, sent him home very happy with a vision of 6/9 with correction. He was followed up by the referring doctor and everything was well till 18 months later. He was referred back, and to my horror he presented similarly. Again the IOL had dislocated and the haptic was rubbing against the cornea, and this time I realized my mistake. There was no PC. In fact, I had put the IOL, as my friend had done, on an anterior compact hyaloid face. So I decided, yes, I have to go in. My first plan was to suture the same IOL onto the iris. So I dislocated into the anterior chamber and very carefully pushed the haptics against the iris so that it will drop into the sulcus. And the other haptic is not so easy, it had to be done bimanually. All was going well, little difficult maneuver, but managed it. I then captured the optic with the pupil, and then I was planning to suture the haptics to the iris. I did one mistake here. I put in some pilocarpine thinking I would hook that optic properly, but instead of that, the lower edge of the optic went behind the pupil, and trying to retrieve that and bring it over the pupil, the upper optic also went below the pupil, and the pupil completely shut down on me. So it was back to the drawing board again, put in some OVD, and my good old iris hooks came to my rescue again. Again dislocated the IOL into the anterior chamber, and this time I had to go to plan B, that was putting in a iris clip lens. And this time I didn't go from the temporal side. I again very carefully dissected a tunnel superiorly, brought out this lens, mind you, all the time I have kept the hyaloid face intact. There is no breach of the hyaloid face. Put in my iris clip lens into the chamber, positioned it, and I used a Clayman forceps and a Sinskey hook to enclavate it. Mind you, this is almost my first case of a iris clip retrofixed lens, so I was a bit nervous. However, it went off pretty well thanks to the videos that I watched of Saurav and Kiranjit. I was able to manage this procedure, making sure I enclavate it, and in fact you can see the haptic coming through. and then I have done an iridectomy with my vitrector. You have to excuse the quality of the video, this is an old surgery, and I sutured the wound. Post-operatively he did very well. His vision was 6/6 with a minimal cylinder, and he has maintained it almost now 1.5 years, 2 years or more. Thank you for watching.